Hello, everyone, and welcome to Faces of Digital Health. I'm joined by Patrick van Oirschot, Patrick, Koch, and Francine de Stoppelaar. All of them are experts in healthcare, more specifically pharmacy operations, medicines management operations, and we're here today to talk about Project Asclepius, which kind of strives to advocate for medication optimization across Europe to improve medication safety and decrease patient harm. So maybe just a brief round of introductions from everyone, just so we understand what kind of drove you to this project. And maybe we can start with Patrick van Oirschot, who I'm going to refer to as Pat in the future questions in this discussion. So Pat, go ahead.
Yes, I'm happy to. I started my career in the hospital pharmacy world 28 years ago in a hospital pharmacy, doing an internship there. Loved this world so much that I stayed there for another year, then worked for over 14 years at a pharmaceutical wholesaler. And since 2013, I'm the owner of Good Pharmacy Practice Support, a boutique consultancy company based in the Netherlands, but working across Europe. Always on topics of digitalization, closed-loop medication management strategy, and one of my hobby projects is 3D printing of medication in a personalized way.
Okay, so that's definitely something that we can also discuss because it's quite a futuristic idea with many potential challenges. But let's not get derailed. Francine, please, what's your background?
Hi, so I'm Francine de Stoppelaar. I have about a 25-year career in healthcare leadership. I am a pharmacist, hospital pharmacist, and also a clinical pharmacologist. Have worked most of my career in hospitals, so a deep contact with patients and deep clinical experience. And the last number of years, I've worked more in hospital management and operations. And my last 8 years, I've been working on a very special project, and it was building an entirely new hospital in the center of London, almost in the back garden of Buckingham Palace, called Cleveland Clinic London. And I was there from the very start, employee number 3. And in addition to doing broad clinical operation work, I also was director of pharmacy there, and headed up the operational activation of the entire hospital, but also implemented a very challenging but amazing closed-loop medicines management system as the first in the UK, based on the US system. So I have now left that project because we did it, and it was an incredible experience. And I'm now doing some independent work and delighted to have started the Asclepius project with my 2 esteemed colleagues here.
Thank you, Francine. I look forward to hearing more from you about the closed-loop medication management system that you implemented. So just before we go into that, Pat, what's where does your passion for medication safety come from?
Yeah, actually, I'm like Francine and Pat. I am a veteran in healthcare, and especially in healthcare IT. I spent the first 20 years of my career in medical imaging, actually. Where I started with analog environments, so film-based radiology, and I must say, I can say that I actively contributed to the digital transformation of radiology. So I really went through the digitization, and all organizations needs to adapt. And about in 2016, I was recruited by one of the leading pharmacy automation vendor, where I had a leadership role. And so I discovered the hospital pharmacy world, and discovered, was really surprised that actually the hospital pharmacy and the medication management area in hospitals is still, I would say, at the Stone Age. This might be a little bit hard word, right? But it's compared to medical imaging, there is a huge gap. And so I left that company about 2 years ago, but I felt I still can contribute to the digital transformation and automation of medication management and hospital pharmacies. And actually, I met with Francine as part of my new last job, and Pat and I also have common interests, and we came up with this idea to create this Asclepius project and align other people with us to basically transform the world.
Mm-hmm. Thank you. And
yes.
Maybe for to better understand the topic, so the project kind of aims to improve or just kind of encourage the improvements in the medication space on the European level. What do we actually know about medication safety in Europe? We have some global numbers. So, for example, the cost associated with medication errors has been estimated at $42 billion annually by the World Health Organization. 2 years ago, the UK created this large study that kind of described in a bit better terms what the scale of the problem in the NHS is, and there's around 1,700 deaths associated with medication errors in the UK. What about the rest of Europe? Where are we with that? Who wants to take over this one?
I'll take this one for now. You've taken the 1,700 deaths words out of my mouth. I was going to bring that particular study to everyone's attention. It is amazing. It was done in 2018, UK-wide, looking at the NHS. We're still making 54 million medication administration errors a year, and as you already said, Jaja, we're sadly losing quite a few people because of medication errors. So we need to do something about this.
Pat, what would you say is the situation in Germany? Germany is very specific in terms of healthcare digitalization. There's been large investments happening on national levels to digitize hospitals. So where are you in terms of medication safety?
I think that that the German market knows that it has to improve. Numbers like $42 billion or euros is not really known over there. But to highlight some other big numbers, we talk about 19,000 deaths per year due to medication errors, not just in hospitals, but also in the home situation. So numbers are big enough to say that this market needs a change and needs improvement.
If you allow me to jump here, there is no certain numbers. And this is one of the issues, and that medication errors are not always tracked and not always recorded in a significant way. So those are only estimates that we have, and they vary obviously country by country. But what is clear, this is a significant health issue, population health issue, because the number of people impacted is significant.
Absolutely, I totally agree. It's not just that medication errors happen. They can also cause harm. They cause complications, prolonged hospitalizations, and consequently costs to the healthcare system, not to mention the harm for patients and their families, because complications have a really, really broad impact. So let's talk about the impact of technology. Healthcare systems are strained on several levels. How can why would decision makers prioritize investing in technology for medication safety, and where should they begin according to your insights and analysis?
It's a great question, Jaja, and if I may return to what you said about the impact of medication safety and medication errors. There is readmissions and returns to theatres and therefore higher costs. So super passionate about this topic. If you look at the closed loop management circle, you have the prescribing, the verification by pharmacists, then the distribution element, everything, all the logistical stuff. Then we have the unit doses and the scanning at the bedside. And all of these digital and automated processes have an impact on making sure that the right medication gets to the right patient at the right time and the right dose. So I understand and that can be a huge investment for hospitals, which we can talk about a little bit later. But reducing harm to patients at any element at any time during the medication journey is absolutely key. So if we look at the various elements of that medication journey, a lot of hospitals are already electronically prescribing, which has a huge impact on picking the right medication and has a safety impact, and verification by pharmacists in real time. But I think that scanning at the bedside, which we are absolutely passionate about and involves individually barcoded unit doses, medications, not only tablets and capsules, but also infusions and injections and nose drops and all the other formulations, is absolutely key, that is done at the bedside. And for that, we do need a certain level of digital transformation and digital processes and automated processes as well. And then we make it safer, which is my absolute passion, but we also make it more efficient, and we are less reliant on the workforce. And we all know that there is a global workforce crisis, which is something we can talk about for a long time. And lastly, I think not to forget, sustainability is absolutely key and is a real relevant topic moving forward globally and across the EU. And these processes reduce medication waste and therefore make our processes and our systems more sustainable as well.
If I may add something to this, it's not just about making things safer and having track of what medication is used, where and when, but due to the shortages that we face in Europe, having a transparency over the whole chain of medication makes us using the medication in the right way and more efficiently. We do not throw medication away, so that medications where we have shortages they are used for the right patient for the right treatment. And this also improves the medication therapy within the hospital. So I think it's more than just about the medication safety, although that's already the most and the fiercest driver for our Asclepius project.
Before we continue, maybe just a few clarifications for the listeners and the viewers. So when we talk about closed loop medication management and barcode scanning, that means that the nurse, when she's administering the drugs, scans the barcode on the patient, scans the barcode on the drug to make sure that the right drug goes to the right patient in the right dose, because everything is prescribed electronically. And when we talk about the whole closed loop medication management, for it to work, several hospital systems need to be connected, from the prescribing system to the pharmacy system to the pharmacy robot, stock management. There's ward cabinets sometimes that are involved in this whole story, clinical decision support systems that are integrated in the prescribing system. So a whole range of systems that basically hospitals need to have in order for all this to work. And in case that, hospitals want to start somewhere and don't just have one monolith hospital system that takes care of everything, laboratories, patient record observations, medications, where would you suggest that, hospitals or decision makers start when they think about improving medication safety, workforce efficiency, and sustainability that you mentioned? Because sometimes it goes gradually. We especially see that in the UK. It started with EPMA, now it's going to the electronic prescription service, and it might go to closed loop medication management next as a kind of national requirement or desire, followed by investments as well.
I think what we did at Cleveland Clinic, which I didn't really elaborate on, was go live with a big bang, because we were a new hospital, and you may just as well, it was a totally paperless and fully digital hospital, you may just as well implement the entire system at once. Very different from a transformation process from an existing situation. And then it is about deciding, you're right, Zaja, what to tackle first. And you are right, in the UK, they have looked at electronic prescribing. They've done that in the Netherlands as well, and other countries. That is something that absolutely needed to be tackled first. There are so many prescribing errors being made. But then secondly, there are a lot of administration errors being made. So in my opinion, the administration side, the safe, secure storage and picking and then scanning at the bedside is the only way to really close that loop on and reduce those medication errors. When it comes to efficiencies, and I'll let Pat talk about that a little bit more, it is absolutely key, and traceability as well. It's absolutely key that we digitalize and automate our distribution and logistical processes within the hospital as well. And it's a matter of what you want to prioritize first, whether safety is the top of your list of priorities, or whether efficiencies and less reliance on the workforce is the top of the list of your priorities. And then, of course, as Pat also said, sustainability is an absolutely key topic at the moment. So it is a little bit up to where the hospital's priorities lie, but I would say that safety and efficiencies are probably the top of the list. And then if you look at the closed loop cycle, then you know where to start and what processes you need to automate and digitalize first. And you're right, to start with something is much better than having nothing. So that's the principle here. Sorry, Pat, you go ahead.
No, that's the thing where I would jump in. In 1996, I was working in a hospital pharmacy where they did have an electronic health record system already in the 90s. They did have something like a medication management system, but there was no closed loop, or there was no digital closed loop. What they did is create a closed loop by doctors and pharmacists working together on establishing the best medication therapy by talking to each other. They registered all the medication that has been given to a patient, not by scanning, because at that time there were no barcodes yet. So what they did was they had unit doses. They had unit doses made with a sticker. The sticker, when the medication was administered by the nurse, was put into the patient record, a paper record, and this paper record was then transformed into the health record system by data typists. So even when it's not fully digitalized, it's not optimal. It all depends. Okay, you have a process, you can work on the process, you can optimize the process. And key element in this is the knowledge that medication safety is for the benefit of all. And secondly, the working groups have to work together, like the doctors, the nurses, and the pharmacists. It depends a bit on the situation of a hospital or a country, where it stands and where to begin. But since it's a loop, it doesn't matter where you begin; you will end up with the whole loop.
Yeah, eventually, definitely. So I mentioned that basically you have a network from several countries in Europe. What can you share in terms of what's the variability in medication management across Europe? What are the country-specific challenges that you may have uncovered, when you all got together? Are the members mostly coming in from private hospitals, or is it also public hospitals? Because that also makes a huge difference in terms of how the hospital is financed and how much they can invest in new technologies.
I think the difference between community and public hospitals, private hospitals, is of a less importance, since we all we have the same challenges in this. Countries might be a little bit ahead when it comes to fulfilling the closed medication management. As I said, in the Netherlands, we had unit dose management already in the 90s. We had legislation for e-prescribing coming in 2014. That didn't mean that only then the hospital started to e-prescribe, because I think almost 50% of the hospitals were already on e-prescribing. But this new legislation catalyzed and accelerated the implementation of closed-loop medication management. And if you look at a country like Germany, where the former Minister of Health has published a new Hospital Future Act, acknowledging that digitalization is of key importance and that all the people within the hospital, all the professionals, have to work together, and supported this new law or this new act by a massive funding, which made it possible for many hospitals to invest into the right resources that were needed. Things like digitalization, so software, or being it hardware. And so the funding was also there. It doesn't come easily, of course, but having the law and legislation catalyzes, and having the funding makes it actionable.
Yeah,
so that from the Netherlands and Germany, but perhaps Francine and Patrick can complete this for other countries.
Yeah, maybe I can add the following. I do see that there are two general methods of dispensing medication. And I would call it the first one, the traditional one, where basically the central pharmacy is delivering packs of medication to the wards, and the nurses are preparing themselves the patient treatment before administration. This is the traditional method, and the preparation work is done by nurses. Of being interrupted and basically creating the possibility of medication errors. Some countries, I think, Pat and Francine, you may say that UK and Germany, for instance, are countries where this method is still the dominant method. The other method, we talked already a little bit about that, the closed loop based on unit dose or patient-specific therapies, started in the Nordics, also in France and Benelux. And here we see that the role of the pharmacy is quite different, is more important. All the preparation of patient-specific therapies is done in the central pharmacy, which leaves actually the opportunity to automate that preparation and dispense into the wards only the patient-specific therapy is ready to administer by the nurses. And so what you see is it's almost kind of a philosophic situation between people or pharmacists leading towards the unit dose, patient-specific dispensing, and the other countries. And in some countries, like in Belgium, where I am from, this is now by law, where you need to dispense patient-specific unit doses. So it's very variable, actually, still between those two methods. And some countries, especially in the south of Europe, are transitioning progressively into the unit dose dispensing.
Mm-hmm. And how do you see that, this whole transition could further be encouraged across Europe? Like, how are you going to do that with your project?
Actually, one of the main obstacle is the lack of standardization, the lack of harmonization, not only on workflows and work habits, but also on information. If you take, for instance, the very basic building block, which is a medication database, every single country in the world and in Europe has its own medication database. And not only the medication themselves are different, so like the names or the dosage, but also the structure of those databases is different. So from a vendor point of view, whatever you are, a software vendor or a robot manufacturer, you need to adapt and recreate every time a local environment. This creates complexity, this creates additional cost, and also risk into the deployment of those projects. So one of the goals of Asclepius is to contribute to the identification of harmonized best practices and promote those best practices through tenders, for instance, to push the industry towards a standardization and so simply a project to deploy.
Touching on what Pat and Patrick have already said, it isn't really about the difference between private and public hospitals. It is really about local regulations as well. For example, we were held back a little bit in the NHS in the UK. I mean, I must say that NHS is loved by many people, but there are digitization or electronic prescribing is not a regulation at the moment, so it's not being driven by the government. It is driven, but it's not doesn't need to be implemented by law. Same for aseptic production. We have a very stringent regulatory body, the MHRA, that sort of prevents us from awarding longer expiry dates, and therefore it's really operationally very complex to implement these unit dose productions for infusions. But then going back to the membership of the Asclepius project, I think what is really key is that we have invited people, and they've gladly accepted to be part of this, that are chief pharmacists in large hospitals with a tremendous amount of experience and also countrywide experience. So some of us are presidents or ex-presidents or key stakeholders in professional organizations on a country level. So we did go about carefully choosing and inviting people so that we have a good representation across Europe. So this is not something that we're coming up with ourselves. Of course, this is our initiative, but it is very much supported by some really key influential chief pharmacists and other key stakeholders, so that we really truly feel we can make an impact by standardizing, using the excellence and expertise of all these chief pharmacists and key stakeholders, and therefore being able to standardize and harmonize processes across Europe, and so that other hospitals can benefit as well.
Do you already have any milestones set up that you would like to achieve?
Yeah, we have defined 3 subgroups to work on. So one is on the harmonization of the workflows, so the processes, standardizing them and making them happen. Am I the only one in now? I don't see the rest of you guys. Sorry.
I see you, Pat.
Okay. And it is in this one where Francine takes the lead together with the other some other hospital pharmacists, chief of pharmacies, to work on that. Patrick is taking the lead in defining but also measuring relevant KPIs where we can see the impact of those closed-loop medication management processes and compare them to each other. So the true belief behind this is, of course, that what you can measure, you can improve. And I'm in the lead of the return on investment subgroup, where we try to monetize the effect of having a closed-loop medication management implemented, to be used by either the ones that have already invested in it, but mainly also for those who are going to invest in it and have to convince, for instance, their management that it does make sense to go into closed-loop medication management. And instead of trying to invent the wheel all by themselves for all these 3 initiatives, we will spread the lessons learned and the best practices over the European countries and the European participants.
So what has been the most difficult thing for you so far, in kind of convincing the decision makers about the importance of this? Because that's the thing, right? With digital transformation, there's always this challenge of first convincing the decision makers, then you have to get the buy-in from the end user. So it's a big thing, yeah.
The main challenge that we face is getting people to take this load, this work on top of all the common duties that they need to accomplish for the responsibilities, the respective responsibilities. So how can we get them to free up the time, and so we can really create that solid foundation of information and deliverable. That's really, I think, the most challenging part of the project.
Mm-hmm. Francine, which part was the most difficult at the Cleveland Clinic in London? What was kind of the biggest challenge of them all? And maybe you can also talk about the impact in the end, the impact, on the results and on patient safety that you've then observed when the clinic was opened for patients.
Yeah, I think we can look at a couple of categories, but one of them was because if you want to truly implement this 24/7 real-time verification, real-time making infusions, etc., you need to be open 24/7. So to workforce plan around this was extremely difficult. So, but we did it, and we found the right people to work overnight and to make sure that we could run 24/7, so the model that we implemented could run. Secondly, it's about getting the people on board and teamwork. So for an example is that we were the first to implement automated dispensing cabinets at ward level in the perioperative areas. The anaesthetists found that very, very difficult. But it was about having good conversations with them, convincing them, hold their hands whilst we were going live to make sure that these processes do actually work in their areas. And they're now really enthusiastic. And then thirdly, again, teamwork. The nurses really, really needed to get on board. We took away the making of infusions from them because we brought that back to pharmacy in order to create those infusion unit doses. They found that difficult. They thought we were taking some pieces of work away from them. And then secondly, to get good compliance of barcode scanning at the bedside, and also to make them use the automated dispensing cabinets in the correct way was difficult as well. So training, holding hands, at the elbow support is absolutely key to make this successful. Now, when it comes to safety aspects, we are currently reviewing all the reported medication incidents over the last 2 years, now 2 years post-opening, and we have some preliminary results to present at HIMSS in Rome in the next couple of weeks. But there's still a lot of analyzing to be done.
Can you already share any of the results that are going to be presented there?
Some rough numbers. We've had about approaching 1 million bedside medication administrations. We have had quite a significant number of maybe not administering in time incidents because of but particularly the beginning, because of everyone getting used to the processes and therefore maybe not things being ready in time. Very limited to time critical medicines. We made sure that those were there at the right time. But if it comes to the 6 R's, so the right dose, right documentation, the right patient, the right med, and the right route, I may have missed one. We probably, or most likely, but I'm still analyzing, have had 2 incorrect administrations, which is, if you compare that to the EPRU report in the NHS that was published in 2018, you cannot really compare it. It's so low that it's pretty significant. So yes, it does work, but it does need a cultural shift to be able to operate this model.
Mm-hmm.
I can add that I could add that in the mid-zeros, where we did also a closed-loop medication management project, that by the prescribing part, we were able to reduce the medication errors by 50%. And by the bedside verification, we could even reduce it by another 50% of the remaining 50%. So we reduced by the project alone 75% of all the medication errors, which is also a significant number, driving us enough to keep doing this good work.
Thank you, everyone, for all the thoughts that have already been shared. Is there anything else that you would like to add before we conclude the discussion? Anything that you think might move the needle further?
Yeah, maybe as a conclusion, I'd like to come back on a sentence that Francine summarized as our mission: make an impact. Really, the goal of this project, Asclepius project, is really to drive the change and initiate actually an acceleration of the adoption of digital transformation and automation in the medication management. At the end, providing higher patient safety and better efficiency. So resulting in a positive contribution for everyone. So really make an impact, and we want to bring all goodwill on board to drive this across Europe.
I will definitely follow how the project is progressing, and hopefully we can follow up in a year or two to see how far you've come. But for today, thank you everyone for sharing.
Hopefully sooner.
Yes, yeah, but it's healthcare, so things happen slowly.
Yeah.
Thank you very much.
Thank you.
Thank you.
Thank you.